All right, let's jump straight into this exam mode explainer drill. We're skipping all the filler to focus strictly on patient stability, diagnostic thresholds, and absolute contraindications.
Section 1. Cardiopulmonary Emergencies. We're assessing immediate life threats. Case 1. A postoperative patient presents with hypotension, JVD, and a new onset right bundle branch block. Your immediate best next step is to assess the right ventricle with an emergent transthoracic echocardiography.
The management-changing clue here is the hypotension combined with that right bundle branch block. This points straight to a massive pulmonary embolism. It's a critical, unstable decision point. Now, a very tempting distractor is CT angiography, but that's absolutely wrong here. Sending an unstable patient into a CT scanner is dangerous. CTA is only the correct choice when the patient is hemodynamically stable.
This perfectly illustrates the cognitive forcing function you need to use. The stability fork immediately dictates that you bypass the CT scanner and go straight for an emergent bedside TTE whenever the patient is hemodynamically unstable.
Moving to Case 2. A patient with anaphylaxis fails to respond to their initial IM epinephrine. The best next step is immediately administering intravenous epinephrine. The crucial clue is the outright failure of that initial IM dose. That's your trigger, your decision point for escalating the administration route. The distractor here usually involves adjunctive therapies, things like antihistamines and glucocorticoids. But those are wrong right now. Those medications only become correct after hemodynamic stability and airway security are fully achieved.
Section 2. Obstetric and gynecologic hemorrhage. Here, we're focusing heavily on exam thresholds.
Case 3. A patient at 32 weeks gestation presents with painless third trimester vaginal bleeding. The best next step immediately is performing transabdominal followed by transvaginal sonography.
The essential clue is the painless nature of that bleeding. That's your specific decision point for diagnosing placenta previa. The distractor you'll see is a digital vaginal exam, which is dangerously wrong because it can cause catastrophic hemorrhage. A digital exam only becomes the right step after an ultrasound has definitively excluded previa.
Notice the absolute contraindication clearly outlined in the management criteria. Absolutely no digital vaginal examination.
Case 4. A patient has a positive HCG and lower abdominal pain. An ultrasound shows a gestational sac in the uterine cornu plus free fluid in the cul-de-sac. Her blood pressure is 80/50. The best next step immediately is surgical consultation and laparotomy. The absolute crucial point in this case is that blood pressure of 80/50. This signifies clear hemodynamic instability from a ruptured ectopic pregnancy. The tempting distractor is methotrexate, but it's completely wrong here due to the hypovolemic shock. Methotrexate is only the right answer when the patient is hemodynamically stable.
Section 3. Trauma and compartment syndrome. We're going to audit the bleeding algorithms.
Case 5. A patient sustains blunt abdominal trauma. Their blood pressure is 85/50. A fast examination shows free fluid in the abdomen. The best next step immediately is an emergency laparotomy. Your key clue is the hemodynamic instability combined directly with that positive fast exam. The distractor of a CT scan is wrong due to the unacceptable time delay it causes in an unstable patient. A CT scan is only correct once the trauma patient has achieved hemodynamic stability.
On to Case 6. A patient has lower extremity trauma. They report paresthesia and severe pain with passive stretching of the muscles. The best next step, immediately, is an emergency fasciotomy or compartment pressure measurement.
The major clue is the pain out of proportion, specifically with a passive stretch. This is your diagnostic threshold for compartment syndrome. Now, don't fall for the distractor of waiting for a loss of pulses. Pulselessness is an uncommon, very late finding. It is not a diagnostic threshold.
Section 4. Toxicology and overdose antidotes. Here, we rely on strict ECG and metabolic parameters.
Case 7. An overdose patient presents with sinus tachycardia, hypotension, and a prolonged QRS interval. The best next step immediately is to administer intravenous sodium bicarbonate.
The clue is that QRS widening pointing directly to TCA toxicity. It's a vital algorithmic decision point. The distractor, benzodiazepines, is wrong here for pure QRS widening. However, it would be the correct answer if the patient were actively exhibiting TCA-induced seizures.
Case 8. A patient ingested oil of wintergreen exactly 1 hour ago. They're exhibiting hyperventilation, altered mental status, and an anion gap metabolic acidosis. The best next step immediately is intravenous sodium bicarbonate or hemodialysis.
The key clue is the altered mental status in the setting of salicylate toxicity. This is the explicit decision point for severe CNS dysfunction. The distractor, activated charcoal, is wrong here due to the very high risk of aspiration. Charcoal is only the right answer if the patient is fully alert and presenting within 2 hours of the ingestion.
Before choosing an answer, ask stability, special host, pregnancy, threshold, contraindication, test delay, safety, and disposition.